What if I told you that the chromosomal abnormalities may have their origins in months, even years before they actually conceive, and that the food choices you make may have a definite impact on the chromosomes of eggs and sperms? Aneuploidy. Yes, aneuploidy. That is the abnormal number of chromosomes which may lead to not only the pregnancy loss, infertility, unexplained infertility, IVF failure, and even the dreaded complications like trisomy 21, the Down syndrome. But what does this aneuploidy occur? Is it a plain bad luck, or folic acid deficiency, vitamin B12 deficiency, or oxidative stress has a role? Even for that matter, does caloric restriction have a role in preventing the aneuploidy? Can aneuploidy be actually prevented? I'm Dr. Rajat. In this video, we'll explore the scientific basis of aneuploidy. How does the chromosome segregation occurs for the formation of eggs and sperms? And what the latest scientific research tells us about the role of nutrition, metabolic health, mitochondrial health, and role of oxidative stress in prevention of chromosomal abnormalities. Watch this video till the end, because by the end of this video, I promise you'll know almost everything about aneuploidy and infertility. What is aneuploidy? What are the chromosomal mechanisms behind aneuploidy? What can be done to prevent the aneuploidy? What is the exact role of nutrition, mitochondria? And what are the evidence-based strategies which can help you prevent aneuploidy and chromosomal abnormalities, help with your fertility outcomes naturally, and help you in better conception? I'm Dr. Rajat, and you have started watching our YouTube channel, The Fertility Gynecologist. Many times when we have to pass on unfortunate news to a patient that this pregnancy is missed, it has ended up in a missed abortion either at 6 weeks, 7 weeks, the first and foremost question in minds of most of the patient is, what is the cause of this pregnancy loss? What did we do wrong? In most of the cases, there is no demonstrable cause of pregnancy loss. The routine causes of pregnancy loss, like diabetes, like blood coagulation disorders like antiphospholipid syndrome, lupus anticoagulant positive, TORCH infections, hyperprolactinemia, antithyroid antibodies. These are the known causes. They account for only 1 to 2% causes of pregnancy loss. In 70 to 80% cases, the cause is not known, and in most of the cases, the cause is of an abnormal pregnancy, of an pregnancy loss, is aneuploidy. Aneuploidy is a common and very natural occurrence in human embryos. This aneuploidy can be during meiosis. It can also be during mitosis. Most of this is during mitosis, that is after fertilization. It is very, very common in most of the early living human embryos. But how much aneuploidy is normal? Why does aneuploidy occur? Can IVF or controlled over hyperstimulation for IUI lead to aneuploidy, or can this aneuploidy be prevented? Aneuploidy is defined as a chromosome number that deviates from a haploid set of 6 chromosomes or a diploid set of somatic cells. It may be due to the gain or loss of the whole chromosomes, that is called as NWC, numerical whole chromosome, or a gain or a loss, that is insertion or a deletion of a part of a chromosome, that is a structural segmental cells. Embryos which look good on appearance, earlier we used to grade embryos on the microscopic appearance. They may not always be the best embryos. They may not always be the chromosomally normal embryos. And that is why, if you refer to my video on pre-implantation genetic diagnosis, the embryonic biopsy, trophoectoderm biopsy, or in next generation sequencing has to be done for the embryos to know the chromosomal intactness of the embryo, whether the embryos are aneuploid or euploid. Because a euploid embryo has got a maximum chance of conceiving, getting implanted, and continuing to a full-term pregnancy. What causes aneuploidy? Whenever there is an error in the cell division and the chromosomes fail to segregate, that is chromosomal missegregation. It can occur during meiosis, it can occur during mitosis. When the sex cells, the sperm and eggs, are created during meiosis, the chromosomes make a copy of itself. It is called as chromatid. And normally these chromatids are supposed to separate evenly into the daughter cells, but sometimes the error occurs. There is an extra or a missing chromatid, and that is what causes an abnormal number of chromosomes. In mitosis, whenever there is a growth and the repair tissue of the body, there is a structural rearrangement, segmentation done, and that is what leads to the mosaicism. The most common causes of aneuploidy is the aging of females, advanced maternal age. It can also be due to the environmental factors like radiation, viral infection, smoking. Let me go to the genetics of aneuploidy. This might sound a little boring, but the prevention and treatment of aneuploidy, the basis lies in genetics. Aneuploidy occurs from the chromosomal non-disjunction, that is failure of homologous chromosomes or sister chromatids to separate during the nuclear cell division. This chromosomal segregation errors mainly occur due to the abnormal kinetochore attachments to the mitotic spindles, microtubules, abnormalities in kinetochore, tubulin, and centrosome proteins, defects in the centromere DNA methylation, and spindle assembly checkpoint. Now, this spindle assembly checkpoint is a very, very important mechanism which coordinates the cell progression during mitosis with the state of chromosome attachment to the mitotic spindle, and several well-characterized proteins contribute to the subsequent steps of chromosomal segregations. This surveillance system detects chromosomal segregation errors, prevents the formation of aneuploidy cells, contributes to their elimination by induction of apoptosis or cellular senescence, and the faulty cohesion of sister chromatids due to the defects in condensins, cohesins, and separases, DNA mismatch repair, impaired telomerase maintenance, and the aberrant multicentric rearranged chromosomes may lead to the abnormal chromatid separation. Actin filaments, which are very close to the centrosomes, may also play an important role in the mitotic spindle assembly because the inhibition of their formation causes impairment of mitotic spindle and disorganized congregation of chromosomes, which increases the risk of missegregation. This both chromosomal missegregation and chromatin separation failure may lead to the formation of two aneuploid daughter cells. One is hyperploid and one is hypoploid. The induction of micronucleus may occur if the chromosomes fail to attach to the spindle and lags behind in the anaphase to the telophase transition. This cytokinesis failure may result from the improper bipolar attachment of the sister chromatids, defects in actin-myosin ring. Progressive telomere dysfunction leads to the chromosomal recombination and persistence of the anaphase bridges with the large intervening chromatin in the cleavage plane. Now, while all this may seem like a bouncer, it may go through our head, but the important point to understand in all these technical terms is that folate deficiency, it induces a dysfunctional long and short telomerase. It leads to DNA hypomethylation, which leads to the increase in micronuclei, nucleoplasmic bridges, nuclear buds, fused nuclei, indicative of mitotic dysfunction, and partial and complete failure of chromatid separation. This folate deficiency has also been known to cause the dysfunction of spindle assembly checkpoints, and thereby it significantly increases the chances of aneuploidy. The missegregation of chromosomes or multiple NPBs caused by folate deficiency, it induces the regression of cleavage furrow, causes cytokinesis failure, leading to the formation of binucleated tetraploid cells, which may significantly increase the chances of folic acid aneuploidy. This mitotic slippage, it occurs when the cells are in mitosis and then exit mitosis without the satisfaction of spindle assembly checkpoints, progress into the G1 cycle without completing the chromosomal segregation and cytokinesis, and as a result lead to the formation of tetraploid cells. This mitotic slippage may also occur if the chromatids fail to segregate during the metaphase to anaphase transition, leading to a fused nuclei, which then become the single tetraploid cells. Mitotic slippage is also known because of the genotoxic agents, which may lead to the telomerase damage because of the damage to microtubules. This is very, very important because most of the patients come to us with pregnancy. They do not plan a pregnancy. For them, planning a pregnancy means the wife and husband, they say that, okay, we want to plan a child, and they plan a pregnancy and come to the doctor with pregnancy. Nowadays, unfortunately, because of the exposure of pollution, because of the exposure of the radiation in form of mobile and the mobile towers, various viral infections, there is an increase in chances of aneuploidy. The folic acid deficiency is very common. Unfortunately, it has got no symptoms, and that is why we always insist pregnancy should be planned. It should not be by chance. Most of the people say that if pregnancy happens, we will keep it. If pregnancy does not happen, it is fine. Pregnancy should not be by chance. It should be by choice. And by choice, I mean planning. Go to a doctor, get yourself examined. The doctor will start a folic acid and a vitamin B12, because this folic acid, vitamin B12, vitamin B6 and vitamin D, as I will allude to in the later part of the videos, plays a very, very important part in prevention of the DNA problems, and most common DNA problem is aneuploidy. Aneuploidy is also very common in control over hyperstimulation, especially IVF. The purpose of ovulation stimulation is to make more eggs. There is a Goldilocks hypothesis. Generally, the IVF specialists believe that more the number of eggs are formed, the more are the chances of pregnancy, which according to me and which according to the Goldilocks hypothesis is not true. More the number of eggs are formed, the more the DNA splittage is there, the more the chances of aneuploid embryos being formed are there. And that is why, in spite of forming 10 eggs, 20 eggs, 30 eggs, 40 eggs, we get hardly 1 or 2 good quality blastocysts. And even if I do the PGD of that blastocyst, that may not turn out to be normal. So that is why the focus is shifting from a hard protocols to high protocols to soft protocols to low dose protocols of HMG and FSH. In my view, 150 to 225 international units, you should have maximum 4 to 8 oocytes which should be retrieved during ovulation stimulation, and that gives us the best chance of getting an aneuploid egg and thereby an aneuploid embryo. I just touched upon the pre-implantation genetic diagnosis. Let me just do a brief. Embryos, just by seeing, we cannot know that this embryo is a good quality or not. The microscopic grading criteria, unfortunately, no more holds good in today's world. We have got an advanced technology that is called as a pre-implantation genetic technology, pre-implantation genetic diagnosis, and we do PGT-A. That means we test the embryos for aneuploidy. We do something called as a trophoectoderm biopsy, which allows sampling of more cells. It is tolerated by the embryo, and it tells us about the chromosome status of the developing fetus. We take 3 to 5 cells, but more in trophoectoderm biopsy. Real-time PCR is important. What we can do in real-time PCR, we can take 3 to 5 trophoblast cells. We can quantify the chromosome copy of each number to a reference tissue known to be euploid. Nowadays, we have even advanced facilities of SNP and CGS, that is single nucleotide polymorphism, and comprehensive genomic hybridization microarrays, which compare the amplified blastomere DNA to the reference tissue known to be euploid. And the readout shows deletions or duplications in higher or lower signal intensities compared to the control. There is an even advanced feature that is called as NGS, next generation sequencing. It takes the fragmented DNA, amplifies in clusters, and sequences it. This sequence are then aligned with the bioinformatics software to reveal deletion or amplification of a specific chromosomes. Science has advanced. Just doing plain IVF, just seeing the embryos or just seeing whether they are day 5 or not doesn't hold good in today's sense. I personally believe there is no point of putting an embryo which is not euploid, and for that you should diagnose whether the embryo is euploid or aneuploid. Especially in case of multiple IVF failures, advanced age patients, advanced male paternal age, you need to get a pre-implantation genetic diagnosis. 2 decades of research in incidence of human aneuploidy has shown that most of the embryos have got some kind of aneuploidy or aneuploid blastomeres at some point of time. What level of aneuploidy or mosaicism is compatible with the normal life, it remains to be seen. The purpose of my today's video is A, to diagnose aneuploidy by PGT, and how to prevent this aneuploid embryos occurrence of aneuploidies. Ladies and gentlemen, according to me, there are 4 ways to prevent the aneuploid embryos. One and foremost lies in your mouth, that is caloric restriction. Second is a growth hormone injection. Third is a DHEA. And fourth is folic acid. I'll make the separate videos on each and every aspect of these things. Caloric restriction, 40% caloric restriction. We human beings require 2000 to 2200 calories per day to survive. Most of us consume more than 3 to 4000 calories a day. This excess calories, it gets deposited in form of belly fat, visceral fat, ultimately signals inflammation, and that triggers oxidative stress. This oxidative stress or free radicals, they ultimately cause damage to the various cells, the mitochondria, and that is where the problem starts. So to address the root cause of problem, you need to decrease 40% of what you eat. So if you are taking around 3000 calories a day, you have to reduce approximately 800 to 1000 calories of your meal. And best time to reduce meals is at night, because unfortunately most of us Indians have a habit of having a heavy dinner, late dinner, and sleeping within few hours of the dinner. That is a dangerous habit as far as our metabolism is concerned. 40% caloric restriction. I'll make a separate video on this because this is most exciting topic. Most of the people come to me after the episode unfortunate event of a fetal demise has occurred, and then they come to me, sir, what did we do wrong? This 40% caloric restriction is what you can do right from next time, so that the chances are that you may not have this again. 40%. It has been shown that adult female mice who have been maintained under 40% caloric restriction did not exhibit the age-relating increase in the oocyte aneuploidy, chromosomal misalignment or metaphase plate, the meiotic spindle abnormalities, mitochondrial dysfunction, aggregation, impaired ATP production. Thus, the caloric restriction during adulthood, not childhood, during adulthood, or maintains the female germline chromosomal integrity, stability, and its proper segregation during meiosis. Many of the pharma companies come with the prescription of a cocktail of antioxidants. This for prevention of female aneuploidy. This cocktail of antioxidants contains coenzyme Q, L-carnitine, and many things, vitamin C, vitamin E, and everything. It might help somewhat, but it cannot be given chronically. This role of antioxidants is based on the free radical theory of aging. The oxidative stress in mouse oocytes reduces the ATP levels and increases the mitochondrial spindle abnormalities, leading to the chromosomal misalignment. Whereas the meiotic maturation of human oocytes can proceed over various ATP levels, it has been shown that oocytes with high ATP levels and greater potential for successful embryogenesis, implantation, and development, and that is where the small role of antioxidant comes to the fore. These antioxidants, especially coenzyme Q, is a mitochondrial rejuvenator. It improves the function of mitochondria, improves the mitochondrial membrane potential, and it improves the ATP levels, and thereby it can lead to a slightly less aneuploid embryos. I'll come to it in the later part of the video, the role of antioxidants. So the caloric restriction without malnutrition, this is a very, very important point. Without malnutrition, that means the important vitamins should be taken either in form of supplements or in form of natural sources. It extends the lifespan and attenuates the severity of aging. The common feature of caloric restriction appears to be the alteration of metabolic regulators that affect the mitochondrial function, dynamics, and accumulated organ oxidative stress in various organs. It acts on growth hormone, insulin axis. It acts on mTOR, that is mammalian target of rapamycin. It acts on AMP, activated protein kinase, sirtuinins. With aging, the meiotic cycle becomes prone to the errors. Higher proportion of aneuploid oocytes are there in the older women, and that is why most of the female over 30 have got trisomy 21, that is Down syndrome. Whereas the incidence of Down syndrome is only 2% in females of 20s. Once they cross 30 and 40s, the incidence increases from 30 to 40%. Aging disrupts the ability of oocytes to assemble and maintain meiotic spindles and tightly align the homologous chromosomes for the segregation at anaphase. Thus, this adult onset, when we become adult, onset caloric restriction, it inhibits the aging associated increase in the mitochondrial aggregation in oocytes, maintains intracellular ATP concentrations, and this impaired mitochondrial function and lower ATP levels are associated with the meiotic spindle abnormalities and failed conception. Thus, the critical need of adequate energy availability in proper assembly and maintenance of meiotic spindles is maintained. So, the primary role of accumulated oxidative stress as a driving force for declining oocyte quality with age, and its inverse role with caloric restriction has been proven. Thus, there are striking benefits of 40% caloric restriction in chromosomal spindle and mitochondrial function. Second most important point in prevention of aneuploidy, especially in infertility treatment, IVF treatment, and IUI treatment, is a growth hormone. Growth hormone not only reduces aneuploidy, it improves the oocyte quality by MAPK3 pathway. Oocyte aging has causes decrease in oocyte quality, loss of chromosomal integrity, spindle defects, and low developmental potential of oocytes. There is a mitochondrial dysfunction. There is a reactive oxygen species accumulation, that means oxidative stress accumulation. There is a decrease in ATP levels, that is an decrease in the energy metabolism function, and the epigenetic changes. Growth hormone restores the mitochondrial function of aged oocytes. The mitochondrial distribution between the young oocytes and old oocytes varies, whereas in young oocytes, mitochondria are distributed around the centrosome and evenly throughout the cytoplasm, while in the older oocytes, they are mainly in the cytoplasm. Growth hormone decreases the proportion of mislocalized mitochondria. It restores the several genes related to the mitochondrial fusion, that is MFN1, and fission, that is NRF2, which are downregulated in the aged oocytes. It also restores the spindle assembly and the reduced rate of aneuploidy in the aged oocytes. Growth hormone, it reduces the percentage of aneuploid oocytes from 40 to 20%. And thereby it improves the developmental potential and the fertilization capacity of the aged oocytes. In most of the females over 30, the levels of growth hormones are less. That is why growth hormones at 1.6 milligram per kg per day are given along with the HMG or FSH during the ovulation stimulation. I personally believe in giving 4 to 8 international units of growth hormone every day along with the ovulation stimulation, preferably started 3 weeks before the ovulation stimulation. If I give growth hormone and if I don't give growth hormone, then there might be a difference of at least 1 to 2 blastocyst embryos, and that is where the chances of success differ. Thus, growth hormone enhances mitochondrial function. It helps by restoring the mitochondrial distribution, elevating the mitochondrial membrane potential, and thus the mitochondrial functions including the protein synthesis, the lipid biogenesis, protein transport, and ATP production are increased. This sufficient ATP generation ensures the availability of energy for oocyte energy, oocyte meiotic progression, early embryonic development. Thus, the growth hormone mediated mitochondrial function enhancement increases age quality and the developmental potential. Third important thing to improve the aneuploidy is DHEA. I'm fascinated by the use of DHEA, especially in the elderly female. I'll make a series of videos on DHEA. Many doctors do not believe in the role of DHEA. DHEA decreases as our age increases. DHEA is important for the androgenic microenvironment around the oocyte, and this androgenic microenvironment, it protects the oocyte from various triggers. It improves the aneuploidy level, and it has got good results in females with decreased AMH. This was about how to prevent the aneuploidy. But aging also leads to the aneuploidy. Chronic inflammation is the major driver of an unhealthy aging. Aneuploidy can induce the pro-inflammatory senescence associated secretory phenotype, that is SASP, either directly or as a result of micronucleus induction leading to the leakage of DNA into the cytoplasm and thereby triggering the C-gas-Sting pathway of innate immune response. We are surrounded by antigens. Antigens are the agents which lead to the increase in the aneuploidy level. We are surrounded by antigens throughout. Acetaldehyde, the things which we use in formaldehyde, which we use for fumigation. Chloral hydrate is an anesthetic agent. Colchicine is the best known spindle poison. Diazepam, anxiety relieving drug. Iconazole and gracefulin, which are antifungal. Pyrimethamine is an antimalarial. Thioimersal is a mercury-based vaccine preservative. Apart from that, radiation, pollution, viral infection, they all are antigens. We can't prevent everything. And that is where the role of folic acid comes. I'll always stress the role of an activated form of folic acid is very important. It plays an extremely important part. The folic acid deficiency leads to the change in the methylation of pericentromeric DNA, which leads to the centromere dysfunction because of the failure of chromosomes to engage with kinetochore and spindle, which further leads to hypomethylation of the subtelomeric DNA anistones and the failure of chromatid separation of telomeres. This leads to the generation of fused nuclei caused by the multiple nucleocytoplasmic ridges, which leads to the formation of tetraploid cells by microtic slippage. That is why the folate deficiency leads to the formation of aneuploid cells, which leads not only to the pregnancy loss, it also leads to the unexplained infertility. The histone modification, methylation, acetylation, sumoylation, ubiquitinylation are dynamically altered during the mitosis in the chromosomes region that are crucial for the chromosome aggregation and regions involving cohesion, centromere function, and kinetochore engagement and telomere maintenance. The post-translational modification of histones are epigenetic markers that can be modified by the nutritional factors, and this may exert aneuploidogenic effects by altering the micronutrient deficiencies, folate and NAD. It may affect by way of affecting methylation of folate, acetylation of NAD, which is a cofactor in certain deacetylase that may impact the meiotic process. This chromosomal aggregation can result in the formation of a lagging whole chromosome during mitosis, which becomes isolated to form micronuclei. Chromosomes trapped in micronuclei in this way, or they often disintegrate and leak into the DNA into cytoplasm, which triggers pro-inflammatory C-gassing pathway. And the cells with aneuploidy or polyploidy nuclei may become senescent. They lead to the activation of SASP, that is senescence associated secretory phenotype, which is pro-inflammatory. The increasing inflammation induced by aneuploidy and the polyploid cells may be attenuated by the elimination of apoptosis and that or chemoprevention, and that is where the role of phytochemicals called as antioxidants comes. The damaging effects of persistent aneuploidy induced inflammation can be mitigated by the use of pro-resolving metabolites, antioxidants, omega-3 fatty acids, EPA, DHA. We can do two things with phytochemicals. We can either slow down the regenerative potential relative to the normal diploid cells or induce their cell death. The chemicals which attenuate the SASP are called as xenomorphics, or which increase their apoptosis or induce their cell death, they are called senolytics. The chemicals like resveratrol or salicylate, they induce the apoptosis, they are senolytics. The research are going on, many pharma companies, every pharma company is coming up with their own cocktail, own dose and own molecule. You name the molecule, carnitine, creatine, ubiquinone, N-acetylcysteine, vitamin C, vitamin E, astaxanthin. The list is long. Well, yes, they may be beneficial to some extent, but chronic application or chronic use of antioxidants, as I'll allude to in the next video, is not much beneficial. It may partially beneficial, but may sometimes be a harmful also. So there are 3-4 carry home messages from this video. If the female is elderly, or there is unexplained pregnancy loss, or there is unexplained IVF failure, there are 3 things that female has to do. A, 40% caloric restriction. You have to reduce your diet. The calories going into your body have to be reduced. Empty calories have to be stopped. Nutrient dense food has to be taken. More amount of physical exercise has to be done to decrease the level of inflammation in the body. Take food and fruits rich in antioxidants, nutrient dense foods like berries, cherries, dry fruits, and folic acid supplementation is must. Any female with borderline low AMH or low AMH, if she is undergoing an IVF, I personally believe growth hormone cycle of IVF is much, and that must, while that may increase the cost of IVF cycle by 30 to 40,000 rupees, but it may give that one good extra embryo. It may reduce the chances of an abnormal aneuploid embryo. It may decrease the number of IVF attempts. And DHA use 6 to 12 weeks before IVF or infertility treatment. These are the things which make the chances of aneuploid embryo less. And the moment the aneuploid embryo is less, the more the euploid embryos, the more chances of conception, the less chances of pregnancy loss, the less chances of IVF failure, the less chances of Down syndrome baby. In next video, I'll focus on folic acid and homocysteine as a mechanism of unexplained pregnancy loss, unexplained infertility, and unexplained IVF failure. Till then, keep watching our videos. Like the channel, like the video, share the video, and subscribe to our channel. Thank you. Bye-bye.